So we are here for another exciting Soulful 7 Conversations. And this one is going to be particularly interesting, hopefully some fun, but also the main mission is to give answers and find relief. And in the title, to find some hope around peri-menopause/menopause. And so I've invited three really established, well-renowned doctors here in town in Nashville. My first is Dr. Sarah Flury. My second is Dr. Vandana Abramson. And my third is Dr. Katherine Haney. And so I want to welcome y'all, and I'm so excited you're here. And we're going to start to lighten the moment by watching a short clip.
I see younger girls, I'm so tickled, and I feel like God has put it on my heart to explain to them what their future is going to be. And it's not bad, but I wish somebody told me. That's the only thing. I think I could have prepared for it better. All right, these precious men that are my age that have already been through this with a woman, they've been with a woman laying in the bed thinking, is that steam coming off of her? Why is she crying because Tanya didn't invite her to the Weight Watchers meeting? That's because she's going through, there's a thing that it can start in your late 30s, early 40s, and it comes in the middle of the night, like a ghost out of nowhere. And it's called peri-menopause. And people should talk about it because it lasts 10 years. And I started going through it, and this is how I knew I was in it. I would sweat at night, here and here. And I would wake up and my hair looked like chicken fuzz.
Okay. Does that resonate with anyone? There's a Christian writer, author, blogger. Her name is Jen Hatmaker, and she's in this age bracket of 40 to 55, even 60. And she said she thinks we should rename peri/menopause, and she gives a couple of ones that I think are kind of funny. She says it could be ovarian retirement, hormotional, brain hiatus. The brain is gone for a little while, and we just hope it comes back. And then Wonder Woman era. I wonder where my keys are. I wonder what I started talking about, and I can't remember what I was talking about. The goal of this evening is to really answer questions. I want you to feel relief. And like I said, I really believe from a spiritual perspective that we're meant to flourish. And I think that for a long time, women have just been quiet, and we've kind of just gritted it out as women can do so well. And clearly, we're in a little bit of a renaissance in women's health, which is such a blessing. And we have social media that has, we have video clips like this that it's hilarious because clearly social media knows that I am 50 because I am getting so many reels now, which tickle me to no end. I wanted to play some other reels tonight, but some of them were a little unholy and inappropriate. But I feel like maybe I should text them to you after the show because they really make you feel like, oh, okay, it's going to be all right. And that thing that I did today that I could not believe I did, actually, all these other women are doing it too. So I do believe, and I think the doctors that are up here on the stage today believe it's true too, that it is possible for us to do this transition, that every single woman who is blessed to still be alive at the age of 40 to 55, that we can do it with a little more grace, that we can have relief and really and truly flourish in what finally we've gotten to this age bracket where maybe we don't have the young kids anymore and we have more time to ourselves, and we should be enjoying this a little bit more. And so my hope tonight is that you will leave with a plan. That you will be like, okay, you know what? Like, I'm going to take this by the reins and I am going to feel better. And it's possible to feel better, right? Okay, so I laugh because I have a friend. The statistic says that menopause is when you have not had a period for an entire year. So you hit that 12th month and you haven't had a period. Welcome to menopause, and you're in it. Basically, that's it, right? Because the ovaries have stopped and you're done. Like, put up, shut up. I have a friend who I will not name her. I don't think she's here, but I just told Katie this. She got to month 11 or month 10 for 3 years in a row. She would get to that month 10 and then all of a sudden, oh, it's back. And she'd have to start the whole year again, which I think, goodness gracious. I know reading the material, our perimenopause can last anywhere from 4 to 10 years. I'm just going to throw some statistics out. One thing that I think that has been revelatory to me is that our hormones that we have always thought were fertility hormones, really and truly, actually, we need them for every single body part and organ to function on this planet with some degree of sanity. And so when our estrogen and progesterone start to either go wonky like this, which I think is what's happening in perimenopause, or start to take that nosedive, every part of our body experiences it, right? So we laugh because, our mother's generation, they just talked about hot flashes. I'm like, I could care less about a hot flash, right? I mean, I don't want hot flashes, right? But I feel like there are other more significant symptoms that we have during perimenopause and menopause that feel like infringe on our lives in a more profound way, and we'd like that to go away or at least get better. So 3 a.m. worry. I mean, where did that come from? All of a sudden, you wake up in the middle of the night at 3 a.m., and you are going through every single thing that could possibly go wrong in your life and in the world, and every single person you know and what's going on in their lives. One moment you're crying, watching a toilet paper commercial that was so sweet, and then the next minute you are raging and you think you might hit that person on Hillsborough Road. Brain fog. Like, I used to have a brain that was sharp as a tack, and you can have days where you do feel like just not as sharp as you'd like to be. And then that bleeds into memory loss. And then, of course, that bleeds into fears of, oh my goodness, I am going to be the one that's going to have dementia and Alzheimer's. Heart palpitations, cholesterol numbers start to increase. Aching bones, aching muscles, your hip hurts, your sciatica bothers you. You gain weight, and you've been eating the exact same thing every single day for the last 10 years, and you can't explain it. Or maybe you don't gain weight, but you look at yourself in the mirror and everything looks a little different. You lose your hair, like in droves in the shower. Raging periods to then spotty ones that linger on for more than the normal 7 days. For me, I put in capital letters, no sleep. And then one of the other ones that I have found just talking to people and doing the research is that women going through perimenopause feel less resilient. So where maybe the normal flux of life that you handled a little more gracefully, everything seems just a little harder. And you don't seem to bounce back in the way that you'd like to bounce back. So I call that just feeling less resilient. Oprah Winfrey just did this isn't Oprah Winfrey, but Oprah Winfrey did a show, I guess, 2 weeks ago. And she said that it normally takes women 3 years to finally say, oh my gosh, I'm gonna have to go see a doctor. Like, this is I've hit the wall. And the doctor that she was interviewing said that when the women come in at 3 years, they do not ask about hot flashes. the thing they say is, I do not feel like the way I normally feel. Like, something is wrong. I do not feel well. And it's usually more mental health than it is even their bodies. So tonight, the big question is HRT or not HRT? What's the risk factor? And for me, logically, and I have said this to Katie in her office, if the hormones aren't there anymore, and they are what make me a happy, full, and supple person in this world, then logically it would seem like we should replace them, right? For skin, hair, body, sleep, mood, heart, organs, my sciatica, hip, everything. We should logically, it makes sense. Like, if you can take them, why not take them? But from talking to Katie and doing the research, it's just not as clear cut as that. And so that's what I'm hoping we're going to get to tonight. And we have Vandana here who's going to talk about it. And so that each one of us can make a really good choice for ourselves. And the other thing is you have said that hormones, HRT, is not the holy grail. Because if you do happen to watch social media or any of these celebrities that are talking about it, they do make you believe, like, well, boy, the moment I put that patch on or I rub that cream on, I mean, I'm going to be back to my 30-year-old self. And so I just want us to be clear that it's, we gotta stay in touch with reality, which is we are aging, can't roll the clock back, but we can feel better. So we're going to start with Katie Haney, who I've known her now for over 20 years. Every single doctor that is on this stage, I have seen personally. I count as a friend, and I trust immensely. And so after tonight, I mean, this is a really wealth of a resource that they will each be happy for you to reach out to. Okay, so Katie, we're going to start with you. Because this is, you have, your career you were delivering babies, but you now are morphing into taking care of women going through perimenopause and menopause. And so I would say my first question is, we sense that we are off. Something has changed. We can't quite put our finger on it, but we just don't feel like ourselves. What should be our first offensive?
Okay, we'll test this mic. I'm going to try to make my voice sound as good as yours here. But I think there are several things. I love the title, that there's hope. And I think one of the biggest pieces with perimenopause and menopause is that it is really real. The symptoms are very real. And they can make people feel kind of crazy or tired or less than. But there is definitely hope. And there are a lot of things that we have really great data to support safety and efficacy for use. And so I think sometimes when I explain it to people, I say that we don't have to be like generations before us where we're suffering through or so scared of certain treatments that we don't seek them out. But on the other side, we don't have to be so, we don't have to go big with hormones either. And we don't have to use high doses or pellets or things that aren't studied for safety and efficacy, because there's just a lot of space in the middle where we really know a lot about how to use them, how to give them, for how long, what time period to use them, that can be really safe. So that's kind of my first big picture overview. And then one really, really important point that I would love to get across tonight is that not everyone is the same when they're going through these things. And honestly, at the end of the day, if someone is, now this would be rare, but if someone came and said, I feel great, like I feel fine, then really hormones probably are not necessary for that person, and we shouldn't use them, because there are some risks, albeit small for most people, when used properly. But if you're not having any symptoms, we really shouldn't use hormones just because they're a panacea or just because they're going to be better for our health or help us prevent disease. And so that's a really important distinction as well. In general, at the current moment in 2025, we don't have data to support using hormones solely for prevention or just the fountain of youth. So those would be the big overviews that I would say.
Okay,
are
so
important.
first thing is you go in and you get blood work done, right? Or this is what I'm going to speak
Okay.
from my personal experience. You go into your GYN and you do blood work, and I'm told you're supposed to do your blood work on day 24 to day 27 of your ovulation cycle. Is that correct? And then you see what your levels are, right? So, and we should be doing that at least once a year. Or if we are hypersymptomatic, we can do it more than once a year. And that should tell us where we are in our estrogen and progesterone levels, right?
Yes. I think in general, that's really a good broad base. I think that there are two separate things. There's perimenopause and there's menopause, and they're really different beasts. And so
Notice she said beast.
I know, right? So in perimenopause, labs can be helpful, but they can be confusing because the hormones fluctuate so dramatically. And so you really need someone to evaluate your levels with you that understands. And then another important piece of the puzzle is how frequently are you having periods? Because that's another key definition for perimenopause versus menopause. So I think there are three things: hormone levels, symptoms that you're having. Again, if you're not having any, then we probably could say we don't need hormones. And thirdly, what's your bleeding pattern? Are your periods once a month, really regular, or are you skipping a couple each year, or are you really having periods every 6 months? And that can help guide treatment as well.
I think the hard part, or at least what I was told, is that you have to hit this one level with your hormones, and then you can take hormone replacement therapy. But until you hit that level, then you're supposed to kind of grit it out. And every month then can feel like 1 month you can say, oh, well, that wasn't so bad. And then the next month you're like, well, that was terrible. How did I make it through that month? Right. And so I think it's hard to know what is that magic number where you're all of a sudden the doors open and they say hallelujah and you can take the HRT. Right.
Right. And I think that we put a lot of stock in a number that we can see on the page oftentimes. But for me, if I'm helping people, there's not necessarily a number on the page that would mean you're a candidate for hormone replacement therapy. It's more, what are you feeling? And are you not sleeping at night? Or are you disrupted at work because you can't concentrate? Or are you so anxious that it's making it hard to drive your kids to school? Or those are the things that for me would warrant treatment more than a number when we're checking labs. So it's really a combination of symptoms, hormone levels, how much your symptoms are bothering you.
Well, one of the questions that was submitted, someone said that they, they were still having periods, but they felt miserable. Right. And so how do you speak to someone that is still even ovulating and having periods, but really and truly are really not feeling that great?
Right. Okay, that's an excellent question. And that's kind of a tough little phase. So I feel that perimenopause is almost harder to treat than menopause itself. Because in perimenopause, hormones are flying up and down, different from day to day, different from month to month. And in menopause, they're just low. And we can give back and treat really simply. But in perimenopause, those fluctuations are what feels really bad. And that is a little harder to suppress or to control symptoms. So it's like you said, every month can be a little different. Each month, like you might have 1 month where you feel fine. A lot of women feel fine right when their period starts. And then the week before their period, they'll feel terrible. They won't sleep. They don't want to be around their family. They are, eating everything in the pantry. And then the day their period starts, they're like, I'm back. I feel fine again.
Yeah, why don't you
And
explain
so
that?
it's a little hard to treat because there's 1 week out of the month where they have troubles, and then the next week they're fine. And so I think the best way to explain it in general is the more steady we can keep hormones and the more or the less they fluctuate, the better people feel. And so it is a tricky time.
And the other
There's
thing you
not
have
one
told
formula.
me is that a lot of times when we're going through perimenopause, actually our estrogen levels can be up here, right? And our progesterone levels can be down here. And so when you do those blood works, it'll show that. And you've said, well, what you could do that actually might make you feel better, because you can't really take estrogen right now because your estrogen's already off the chart. So what we'll do is we'll give you some progesterone, and then the progesterone moves up and we kind of close the gap a little bit better, which would then make you feel more balanced. Is that correct?
Agree completely. Yes. Yes. So often in perimenopause, estrogen levels are really high, and they're really high and they're fluctuating at high levels. And then progesterone levels can tend to be very low, especially right before a period. And so sometimes something as simple as just giving a little bit of progesterone to make those two a little closer together feels more comfortable. And it can also balance or make things just a little more steady every day. And our bodies like for our hormones to be kind of steady every day. It feels uncomfortable when our hormones are fluctuating.
Okay, so this is the pedestrian explanation. So I'm just going to start it, and then you come in with the professional. So my understanding is during perimenopause, we know we're born with our number of eggs. We don't get any more. We just lose them as we get older. So our body likes it when we ovulate, right? And so the brain is consistently sending these signals, you should ovulate, you should ovulate. But as we get older, there are less eggs, and I think our ovaries are a little tired, so they're not as interested in doing what they used to do, retirement. And so the brain is going cuckoo for Cocoa Puffs, like, no, 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 no. We need this estrogen. We're going to do this. Let's keep sending the signals, keep sending the signals to the ovaries. And that wackiness is what makes us feel off balance, right?
Yes.
That's the pedestrian explanation.
Yes, that's exactly right. I agree. I think when you're 20, the amount of estrogen or the change in hormones that trigger ovulation are milder. And when you're in your late 40s, in order for our bodies to ovulate or to have a period, the fluctuations in hormones are huge. And the brain is sending more and more signal to the ovaries because the ovaries are like, I'm kind of tired. And so
I'm not making babies anymore. So it's like, I'm not going to work.
yeah, I might not do that this month. And next month, maybe, but we'll see. And so I think that those fluctuations and those signals the brain keeps saying, can't you give me an egg? Can't you give me an egg? And the ovary's like, I'm trying. Those are what feel uncomfortable. That's
Okay, and then while we're on the subject of the brain, and so what happens is the amygdala in the brain, which is not getting enough estrogen, or is it going, oh my gosh, like things are not going well in the body, so the amygdala all of a sudden just ramps up and gets crazy, and that's what makes us feel all of a sudden, where maybe our entire lives we've been so balanced, and then all of a sudden we are like anxious. We're waking up at 3 a.m. worrying about things that we would never have worried about before, and we certainly wouldn't have woken up at 3 a.m. So is it the amygdala that's getting not enough estrogen, or?
I think that is somewhere, there are lots of studies happening right now with estrogens, menopause, progesterones, and the brain that are going to be hallmark studies that will help guide us and help us understand how to take care of women, how to prevent dementia. And I think really honestly, within the next 3 to 5 years, we're going to have so much more information about how hormones affect the brain around perimenopause and menopause. At this moment, though, it's a little hard to say, is it the lack of estrogen that makes the amygdala have fight or flight or increase anxiety? But what we do know is that our brain changes due to the changes of hormones from perimenopause and menopause, and the way the brain uses energy sources and the way the brain uses neurotransmitters changes, and our temperature regulation center is in our brain as well. And that is part of what makes menopause so hard. But I really think that we also have to be super careful, again, when we think about using hormones to treat certain symptoms. We really have to be careful to not use hormones specifically to prevent dementia. And so that's really an important point. Now, 3 years from now, we may have more information to help us do that. And then back to your question about anxiety. This is kind of the best way I have to explain it. When hormones change, it can be a trigger for mental illness. It can be a trigger for anxiety, a trigger for depression. And again, hormonal fluctuations are what our body doesn't like. It doesn't feel very comfortable. And so postpartum depression, it's because hormones are changing tremendously. Same with perimenopause and menopause. Our hormones are fluctuating tremendously. And those hormonal changes can be a trigger for anxiety and depression and mental health. But it's really important to think about it in this way. We can maximize everything we can with hormones. So we can treat your symptoms, we can maximize, we can give back hormones if we think they will be beneficial and safe. But anxiety and depression and mental illnesses, even though they can be triggered by these hormonal changes, really deserve to be named and treated in their own right as well. And so I think that having an honest discussion, being open about how much anxiety is affecting your life, is it getting the better of you? Same with depression, same with any other mental change that happens with hormonal fluctuations. It deserves to be named and treated in its own right as well, and not just being treated with hormones necessarily.
Okay, that's good to know. I want to go back though to this when we can safely take the HRT, and then also how long we can take it. So my normal GYN says, and Mary Claire Haver, who's blowing up on all social media channels, she says once you go on it, you can be on it forever. Whereas I've read in other studies that basically it after 60, it's like diminishing returns, and that might mean the risks go up of why you should probably come off of it. So I'm just curious, like, is it like a one-time fun drug that we only get to take it for 10 to 12 years? Or is it something we can take all the way till I'm 98 years old?
Okay, great question. Currently, with the data that we have, you should use hormones for the shortest amount of time necessary to treat symptoms. Oh. And so I think that, and that's because in reality, hormones can cause blood clots and strokes, and we don't have proven benefit for prevention for heart disease or dementia. And so really, I think that sounds not hopeful, kind of, but they should really be used for symptom control, not for the fountain of youth. And we should use them for the shortest amount of time necessary to treat symptoms that are really impacting your life.
I think, though, Katie, you saying that automatically, people are going to say, well, gosh, if I only get to take it for this certain window of time, then should I not just grit it out, right? If it's just, 8 to 10 years that I'm not going to feel 100%, but I know that eventually it's not good for me, so I should go off of it. Should I even go on it in the first place? And then, right? Huh? I know, we're getting to you too. I promise. We're coming to you. We're coming to you. Maybe I'll skip around with questions so that Katie's not like on the hot seat.
Okay, well, I will say one thing about that. I think that as time goes along, so when we're 65, our risk for a stroke or a blood clot, just inherently, like normal, healthy people running around doing their everyday life, our risk for having a stroke or having a blood clot or promoting heart disease increases with age. And so our risk for things that hormones can increase our risk for as well increase with age. And so when you're between the ages of 50, 55, maybe even up towards 60, your risk for those things is less. And so we feel a little more comfortable giving a hormone that might increase your risk. At 65, the risk for a stroke is pretty real. And so you've got to weigh that benefit and risk. And is your symptom impacting your life enough that it makes it worth taking, even knowing that there are some risks? Does that make sense?
Well, I will say that my mom, she had a hysterectomy because that was very much, popular in her age group. Like all of her friends, their doctors were saying, "Oh, you just should get all the parts out," and so then they, automatically have to go on HRT. And I will say, I think that it did help her age better. Like, from skin to hair to personality and mood and all of those things. She took it from that window of like 50, I think, to 60 or 65. And then she did start having some funny symptoms. And so she had to go off of it, which when she went off of it, she had to go through all the brutal stuff again. So maybe we now know we can temper it a little bit instead of going hardcore off of it. So would that be a positive, hopeful thing to say, hey, listen, we're going to do it for 10 years. It's going to help us in our bodies and our faces and our hair and our muscle and all that stuff. And it's just the 10-year window. And then we're all going to know that when you hit that 60th birthday, you should start thinking about coming off of it.
Yes, or at least trying to limit your exposure or lower doses so that you still feel good, but have less exposure to hormones. So dose does matter there too. And I think with Mary Claire Haver, I think
she
her
does say it's
information
the
is
wonder
great.
drug.
I think her information is great, and I think she's started this revolution or this renaissance for menopause, which is awesome because women are talking about it now. But I personally, that is one place where I disagree with her. I just don't think we should go on hormones and use them for the rest of our life because it's the fountain of youth.
Okay.
So she and I have a little disagreement there.
Okay, so we're going to just stick real quick because we're on hormones. So there are a couple questions, and then we're going to move into. So I have 3 different friends. They've gone to 3 different doctors. One of them is on the patch, one of them is on the cream, and one of them's taken the pill. And I'm just curious. Oh, and they also, there's the where you can go to a special, get it bonded, or you can just get it at the Walgreens, and so I'm like, well, okay, so if we've said yes and we're signing up for that 10 years, how do we know what is best for us and which one to choose that's going to be the most effective? And do we need to go to that special pharmacy, or can we just go to the Walgreens down the street? And is Farrell Mason going to be better on the patch, but you're going to be better on the cream? Like, how do we know which one, if we're going to say yes, to choose?
Okay, great question. I think the real answer sits in it has to be personalized for each person, and it has to fit with their own personal history, health history, their family history, their genetics, their environment, their lifestyle. And so it's really variable.
Okay, so talk to me. Who gets the patch?
Okay.
Who's the patch the best for?
The people who don't want to mess with a fussy cream.
Okay.
But patch and cream are both absorbed through the skin. Mm-hmm. And there are some benefits to absorbing estrogen through the skin in that you don't get the first pass, so your liver doesn't have to metabolize it as heftily. And so it doesn't affect your triglycerides as greatly. It decreases risks for blood clots if you can take an estrogen that is absorbed through the skin. Progesterone should always be oral. And then you ask about compounded. Mm-hmm. So that's a really great question too. And I think that it goes back to the staying in the middle of the road with safety and efficacy data. Compounded hormones are just a little bit fuzzy. And there's not standardization. And so it's a little hard to know exactly what you're getting, how you're going to absorb it, how your body's going to process it, because there's not a standard. And each compounding pharmacy makes them differently. So in general...
But is that considered more organic, though, to do the compounded? Right? Is it a little healthier to do the compounded?
I would warn against being sucked in by what I call marketing terms, bioidentical, natural, compounded. I think it's easy to think those are healthier, but they're really not. What's healthiest is hormones that we've studied really, really well, and we know exactly how they're absorbed, and we know exactly how they work so that we can use them safely and effectively.
Because there are doctors on the market right now.
Yes.
You know, and I've had a friend fly to Los Angeles to meet this one specific doctor who tailors the medicine for what he says for your specific body. It is compounded, and she says that it is better than what I would go and get at the Walgreens on Hillsborough Road. So I'm just saying, if we're going to do this for 10 years, we want to figure out what's the best one to do, right? If this is going to be making us feel better. So I'm just trying to get in there and what would be the best one for Farrell Mason to do?
Okay, I strongly feel like the best hormones are the ones that you know will be safe and effective.
Okay, so what is that?
And there's
That's going to
just
Walgreens.
not data for compounded hormones.
Okay, you're hearing it here. All right. Okay. Okay, so perimenopause, we're not quite ready to get on the patch or the cream. And so a lot of doctors are saying, well, then just get an IUD. And that the IUD or low-dose birth control pills, what you would have taken when you were 20, that actually will take the edge off. And that might get you a little further along before you need to actually do the deep dive. Is this true?
An IUD won't treat symptoms of perimenopause except for irregular bleeding. And so it can be instrumental if you have heavy periods or periods that are getting a little closer together, or you're a little anemic because of heavy periods, or just don't want to have to fuss with your period every month. IUDs are awesome for that, but they don't give you systemic hormones.
Okay, so
They don't go to your brain.
So the progesterone that's in the IUD, that's not really going to make me sleep.
Right, exactly.
Okay, well,
not at all.
We're moving to the big stuff then. We don't need the IUD, right? Okay, we're leaving that off. Okay, I want to hit back on, because we're talking about relief, and I know that you are a big proponent on the progesterone because that does help with anxiety, it does help with sleep, it does help with making you feel like you're a little more balanced in the world. So who can go ahead after tonight and get a prescription for progesterone? And she's already told us it has to be a pill. So who can get that? Who can sign up for progesterone?
Well, I think anyone who goes to their doctor, and hopefully someone who's well-versed in hormones and menopause, and can talk to them about their health history, make sure you don't have contraindications, like having blood clots or needing a blood thinner at any time in your life, or having a strong family history for strokes or pregnancy complications. So there are things that can be contraindications, but if you can go to your doctor and have a conversation and you have symptoms, for example, less frequent periods, sleep disturbances, increased anxiety, brain fog.
Does it help with hair loss?
Candidates for progesterone? No. Not really. Hair loss is kind of in its own world.
Yeah, we're going to hit that though. Don't worry. Okay. All right. So, Miss Sarah Flury, you're up. So while we're on hormones, you are going to talk about and celebrate vaginal estrogen. So talk to us.
Going to.
Why? So basically, we all want progesterone and we all want vaginal estrogen. And so now you're going to tell us
estrogen.
why
Everyone wants vaginal estrogen.
Every single person in the room
That is a good take-home message.
should get it.
Just for a little background, I'm a urologist, so I don't really treat menopause, but there is something called genitourinary syndrome of menopause, which used to be called vulvovaginal atrophy, which doesn't get talked about nearly as much, but is very important. It leads to vaginal dryness. It leads to pain with intercourse. It leads to urinary tract infections, which I do treat every day. So I am a big proponent of vaginal estrogen. It is not HRT, so to speak. It is not absorbed systemically at all. So you can safely use vaginal estrogen without fear of any of the repercussions of estrogen. It's a local treatment, so you're kind of treating it at an end organ level as opposed to taking it systemically and worrying about even breast cancer, which we're also going to get into. So that's a very common question for me is, can I use vaginal estrogen if I have a personal history or a family history of breast cancer? And the answer in my mind is resoundingly yes. I do encourage people who have had a personal history of breast cancer to speak to their oncologist, but ones who are reading the studies and up to date on the actual answer to that question, I'll say yes. So, of course, I'm never going to tell someone to take vaginal estrogen if they don't feel comfortable about it, but I will educate them that I do feel comfortable about it, and it's based on studies, and therefore I think they should too. So vaginal health is, urinary tract health for men and women, vaginal health, and then male reproductive health all fall under urology. So I do end up spending a lot of time talking to people about changes, vaginal changes with hormones, with menopause. And urinary tract infections is the number one, pain with intercourse and urinary tract infections are the number 1 and 2 symptoms for perimenopausal women. And vaginal estrogen is easy to use. It comes in several forms also. Estradiol is the main ingredient, and most people use it as a cream, but there's also a ring or a tablet. And do you want me to go into this part now?
Yes. Honey,
Okay.
every little bit.
Yeah. And so you basically use it nightly for 2 weeks, and there's an applicator, or you can put it in with your finger, but you're trying to rebuild your body's natural barrier. The vaginal epithelium is thick and healthy when estrogen is there, and during menopause it thins, and it's much easier for bacteria to go from the vaginal vault into the urinary tract. That's one of the main reasons that UTIs increase. And another is the change in the pH, vaginal pH. So the microbiome of the vaginal vault is very important. Lactobacillus is the most prevalent bacteria vaginally, and it makes lactic acid as a byproduct, which makes your vaginal pH be acidic and unfriendly to bacteria. And in menopause, that goes down, and it becomes friendlier to bacteria, which have an easy time getting into the urinary tract. And actually, vaginal estrogen is the most well-proven prevention of urinary tract infections, and it's an incredibly common problem in menopause. And I mean, half the women I give estrogen to vaginally never get a UTI again. It's pretty amazing. And so that's a good reason to use it.
Because like you said, so UTIs, I forgot to list that in another one of the symptoms that people have, but UTIs, rapid increase in getting UTIs, that all of a sudden maybe your whole life you never got a single one, and then you could be having them every single month.
Much more
And
common.
so the roller coaster of taking antibiotics, and what is the other thing that they prescribe when you have they give you the antibiotic and then they give you the
Fluconazole, yeast infection.
yeast infection thing, yes. You got to take the 2 of them. And so you're saying cut all that out because it's really not good for you. Really not good for you to do that constant taking the
Yes.
antibiotics.
Yeah. Well, that's another problem, actually. And postmenopausal women get something that's called asymptomatic bacteriuria. So they get bacteria in their urinary tract, but it's not actually a urinary tract infection. It's related to the changes in the microbiome. And you can have E. coli in your bladder that are actually healthy and not causing you UTI. So I see tons of women in their 70s and 80s who get a urinary culture just because their doctor sent it, and then they think they have a UTI and they get treated, and then they develop resistant bacteria. So trying to be, an antibiotic steward, prevention is better than constant treatment with antibiotics, because that again is going to lead to this vicious cycle where you're getting yeast infections, you're having to take more antibiotics. You aren't actually clearing it because it doesn't really need to be cleared. It's not causing you health risk. So building up vaginal estrogen can help prevent all of that. I think everyone should take it.
Okay, so everybody should take it. So we now have 2 things that we can do that are going to help us. But
Hope.
Will you go back with how do we do this again?
Most
and how
common,
often?
Yeah, so estradiol vaginal cream has an applicator, or you can put it in on your finger. You apply it vaginally, and you do it nightly for 2 weeks, and then you do it 2 to 3 times a week at night for maintenance. So most people do it
every single month.
every single day. Yes, every single month. So for 2 weeks continuous.
Is it a certain time in your cycle that you're
Nope.
supposed to do it? No,
doesn't
just
matter.
2 weeks. Every month we should be doing it every single day for 2 weeks. And then after that,
So sorry,
maintenance.
just when you start it, you do it every day for 2 weeks, and then into infinity,
Oh,
twice or 3 times a week.
okay. So just 2 weeks and then maintenance every month after that.
You got it.
Okay.
Yeah.
That has nothing to do with libido. That is not going to help the libido.
No, not that. I wouldn't say nothing to do with libido. It doesn't. There's a hypoactive sexual desire. It doesn't really fix that, but it does increase. It increases blood flow vaginally. It decreases pain with intercourse. So those all kind of go together. Multifaceted reason that women are avoiding sex in menopause, and pain is one of the most common ones, but decreased blood flow. And vaginal estrogen helps build up your vaginal epithelium and makes sex less painful and makes it less likely to be traumatic and less likely to lead to UTI. And so, yeah, I wouldn't go as far as saying it's going to fully boost your libido, but it does make the whole interaction less painful.
While we're still on hormones, what about testosterone?
That would have to, I don't do that for women,
Okay.
only men.
Okay.
Okay,
Katie
I'm
does.
going to just say one more thing about Mary Claire Haver.
Okay.
Maybe that.
She's been ruminating.
Maybe that's
We're
what
going to
she meant.
post this and she's going to come after us.
No, I love her. I think
Yeah.
she's done such a good service
Okay.
for women, but maybe that's what she's talking about, because I think you can use vaginal estrogen for the rest of your life.
Definitely.
Right?
That's
Oh,
right.
you can
There
take
you
it
go.
back.
That's what
your
she's
life.
talking about.
Yeah, more hope.
Maybe so.
Okay, testosterone, man, can of worms.
That goes
So-
into the libido thing, though.
It does.
Right? So that's why I'm.
Yeah. Okay, so I think that testosterone is truly a can of worms. And I honestly believe that for most women, we can treat low libido with vaginal estrogen or systemic hormones more safely. And there's a reason why we don't have an FDA-approved form of testosterone for women.
But she is taking it, testosterone. Mary Claire Haver.
Yes.
This is in her
Yes.
cocktail.
I know.
She's taking it. Yeah.
Right. It
and
is in
she
her
says
cocktail.
it makes
It's
her
in a
feel like
lot of people's
Superwoman.
cocktails.
Yeah.
I think that testosterone is a slippery slope, and you can speak to this. Maybe you should speak to this, but there are definitely untoward side effects that are irreversible.
Okay, what are those?
Okay. Well, you lose hair where you want to keep it, and you grow hair where you don't want it.
Oh.
And you can have a deepening of the voice, and then there can be some definite urologic, like clitoral enlargement that never goes back. But
That's true.
tell me if you've seen that and describe it. Are you fine?
I haven't.
All right, guys,
really
I think maybe you know.
We don't want that. Avoid.
Avoid.
Okay.
Avoid. But that's typically with high doses of testosterone for like 12 to 18 months, which is real. A lot of people do this. And so I think that the other problem with testosterone is that it is marketed as this awesome thing that will help you be young, have the best sex drive, have muscle tone, build your bones. And really, there's just not data to support that. And there's certainly not data to support safety. So if it's being used at all, which I think we really can conquer the problem in a lot of safer ways. But if someone decides to use it, I think it should be monitored very, very closely. You should never take supraphysiologic doses, which means doses higher than a woman would see naturally in her lifespan. And really, really, that is a place where you shouldn't just be going to a clinic that does pellets. You should be really seeing someone that can help monitor you in a safe way. So,
Okay.
and one more thing, testosterone in the studies that are really eloquent and well done helps about 50% of people with libido. And as you can imagine, libido is super hard to study because you're asking people about like their sex drive, and it's so variable, and there's so many things for women that factor into it, like our body image, how we feel about what our husband said to us, you know, what we watched on TV that night. So libido is so multifactorial that it's really, really hard to study. So about 50% of women who did use testosterone saw a marginal benefit with libido. And what we know about placebos is that people get about 40% of people get a benefit from a placebo, which means a sugar pill. So testosterone is really a can of worms.
Okay.
I generally would say avoid if possible.
Does hormone replacement therapy help with libido?
Yes, resoundingly. Even vaginal
Yes,
estrogen.
even vaginal estrogen. And there's
Okay.
Mona Lisa laser. There's all kinds of things for increasing blood flow vaginally that definitely help. Well,
Okay.
to be studied more, but look like they're going to help.
So I'm just going to recap real quick, right? So we're all going to go home and we're going to talk to whoever we want to talk to about progesterone, and we're going to talk about vaginal estrogen. We're going to maybe be hesitant on testosterone. We are going to have a marvelous, if we decide to get on HRT, we're going to have a marvelous 10 to 12 years, and that is going to be amazing, right? For 10 to 12 years, if we decide to make that big leap. And then after that, we're going to go off of it because it loses its benefit and we don't want to have strokes. Is that a good summary?
I love it.
Okay, so now we're going to talk about the risk, right? We now know all the benefits. It will make us feel better to be on HRT. And I have seen it proven that it does help you with skin and body and hair and sleep and libido and all of these amazing things, and your sciatica and all of those things it does help with. So you're going to do your due diligence and you're going to talk to your doctor, you're going to call Katie, and you're going to decide. I still am not sure when that magic moment is that you can say, I'm getting on the patch. I'm still not sure. I don't know if we've clarified that, really clarified. When can you have the green light? Because you want to do it, from what I've read, to get the benefits for the brain and the body. You want to do it before the 12 months of no periods.
Yes, I think sure. I think depending on when you have symptoms is when you use it. So, but one thing I wanted to say too is that progesterone tends to be more helpful in perimenopause. Mm-hmm. And then once you solidly are into menopause is when estrogen becomes more helpful for
sleep.
symptoms.
Okay.
And sleep. And estrogen, if you have a uterus, has to always be married to progesterones.
Okay.
Always go
All
together.
right. So after this, we'll dive back in for questions, but we're going to move on to risk. And obviously, with all the studies, the main risk and why a huge generation of women did not do HRT was because of the risk of breast cancer. And so Vandana is like not only like the most well-known doctor here in Nashville, but also like across the country, very well versed on this. And I am a patient of hers, so I actually asked her, and I asked her nurse practitioner, and I asked another doctor in the office, are you going to take HRT? And they all said, no, they're not, which gave me pause, obviously. And Vandana said that she would treat symptoms first with other options and then would consider HRT. But I know you're maybe going to speak on that for a minute. So there was that big study, what do we call it? The National Health Study. And that's the one that came out that said, oh gosh, like backpedal, don't take HRT. There is a breast cancer risk. There is a risk for more strokes, heart conditions in women. And so we backpedaled, and people got really fearful about taking it. Now we've done the research on that one particular study and realized that it was looking at women that were over the age of 60, right? You talk about it,
Yes.
not me.
Hello.
Yeah.
And thank you for
Sorry.
doing this.
Yeah.
This is wonderful. So, yes, the Women's Health Initiative, there really hasn't been a study that's been more controversial and more anxiety provoking. But basically, it looked at hormone replacement therapy. And I think one of the things that we have to point out is it included women who were 50 and older, so 50 to 70-ish, and a lot of the average age was 63. So a lot of people started hormone replacement later after they were well through menopause. And the other thing to point out with that study is that it was synthetic hormones. So it wasn't some of the hormones that you were talking about, which we know are associated with an increased risk of breast cancer.
Real quick, Vanna, will you tell me what that is?
Yes. So
Okay,
these are
synthetic.
not, these are like estrogen would be derived from a horse's urine. That's where that.
So we're not supposed to do that anymore.
That synthetic estrogen isn't used quite as much. I'll defer and back to Katie for that, but that's not usually what we are giving these days. So, there is an increased risk, but the risk was probably overstated because it was stated for the whole group. And in May of 2024, that same group of investigators went back and published the 30-year follow-up. And they went and said that for women between the ages of 50 to 60, the benefit probably outweighs the risk. And when we talk about the risk, you hear 29% increase, 30% increase, that sort of. It's important to remember that's a relative risk. So if you have a 50% increase, but your risk was only 1%, then it's gone to 2%. So, that's key there, because when we talk about a 29% increase, that may be somewhere around 1 extra to 2 extra cases of breast cancer per 1,000 women taking hormone replacement. So, it's not huge by any means. And then you can sort of say, well, that was also with these synthetic hormones. So I would say, to say it does not increase risk is not telling the full truth. But to say it really increases risk is not looking at the data properly. And what we really need to do is look at data for the hormones that we're using today. And there really aren't great studies on that. There are large studies from the UK that were retrospective, and they seem to indicate that some of these body identical hormones, as in hormones that are FDA approved, not the ones that are compounded, that have been studied and are out there, probably do not increase the risk much at all, if they do. Possibly, but I would never say they don't increase the risk, as I've seen written in various blogs. I think that there's a possibility that they do, but the risks are relatively small when used for 5 years for sure and up to 10 years. Beyond 10 years, we are looking at a greater risk, but again, how high is that risk? That's going to come down to your personal attributes.
Would you say, though, that we've seen an increase just in general of breast cancer?
Yes, we are seeing
increase. Can you speak to that, like your numbers? Because I know you said your office you have lots of people coming in with breast cancer diagnoses, right? So what is our general increase in breast cancer?
So we are seeing, it's always hard to parse out, because we know that more people are being screened, people are living longer, people are more, and the community hears about it more because people are more willing to talk about it. Mm-hmm. But we are definitely seeing an uptick in younger cases. So for a while, we thought it was earlier identification, et cetera, but we were really definitely seeing an uptick. We don't know what that's from, and that's not hormone replacement, because those are younger people not on hormone replacement. And also just important to point out that the cancers caused by hormone replacement therapy are not usually the ones that people pass from. They don't usually lead to metastatic disease. They're usually small estrogen receptor positive, more easily treated cancers. But also not to forget that if you are diagnosed with that, you would have to take an anti-hormone.
So what that means is you get diagnosed with breast cancer, all of a sudden she is going to take all of it out of your body. You are going to be at bottom level, no hormones in your body for the rest of your life.
Yes. Well, we would stop the hormone blocker after 5 to 10 years, but we would not recommend taking hormone replacement, because there are studies that have shown that the risk of recurrence by taking it is actually pretty significant.
Okay. And then how do you treat your patients that they have a breast cancer diagnosis, they have gone off hormones, but then they have all of the awful symptoms of menopause?
Yes.
And you can't treat it with hormone replacement?
No. So we do use SSRIs to help with hot flashes. There's a newer drug called Veozah that's a neurokinin 3 inhibitor. So it works more on the brain. Mm-hmm. That can be really, really helpful with hot flashes and all kinds of other symptoms. We do have to monitor liver function tests with that to make sure that the liver isn't damaged. But for the most part, that works really well. And then vaginal estrogen is helpful as well.
Okay. And then you said there are other tests that are being done right now that maybe would help us understand maybe the landscape a little bit better.
Yes. So,
and those are tests that you can test, because she said she's going to test on me. That all of us, we're going to get the test. what would those be and what will they tell us?
Okay. So this is a newer thing, and I really want to emphasize that we don't have all the data. So, I'm always really, really careful, as we all are, about what do we have data for and what do we not have data for. So we've all heard about BRCA testing, BRCA testing. That's basically a gene that we all have. And if you have a mutation in that gene, you're more likely to develop breast cancer in the future, 50 to up to 70, 80% risk of developing breast cancer.
If you take HRT or just in general?
In general, if you have the BRCA mutation, which is why for BRCA mutations, we generally do recommend prophylactic mastectomy, which is pretty extreme, but that the risk of developing breast cancer is so high that we do recommend it. BRCA testing's out there, we know that, but then if anyone here has had testing for any of these, for BRCA or genetic testing, there are all these variants that show up, and no one really knows what to do with the variants. There are other genes. And most of you have heard of 23andMe, which also was able to show us that that you might be at risk for a certain disease. So what 23andMe was looking at was at SNPs, which are single nucleotide polymorphisms. Sorry, I'm not going to get too technical for more than a minute, but this is, I think, very interesting because I think this is where medicine as a whole is headed. So SNPs are basically a change in your DNA. So, that thymine becomes an adenine or whatever. And any one of us has about 4 to 5 million SNPs in our body at any given time because they're just changes from normal. And they're called SNPs once 1% of the population has that change that everyone else doesn't have. And what we can do now with these SNPs, because of these whole genome-wide association studies that have been done in the past 20 years, is we can see what these SNPs actually mean. So you mentioned dementia or Alzheimer's dementia. So this is a very well-studied SNP. If you have a SNP in the ApoE gene, there are two particular ones, then your risk of Alzheimer's is much higher. And the same applies for other diseases. So for breast cancer, there's a test that looks at a bunch of SNPs. One of them, the one done by Myriad, looks at 308 SNPs. And you add up the SNPs, basically. It's an additive sort of thing, and it can give you a risk assessment of your risk of developing breast cancer. I would say, again, we need prospective studies to really say what this means, but this data is based on retrospective good data. We still need the future. We need those prospective studies. But there have also been studies that looked at hormone replacement therapy in people with higher the test itself is called the polygenic risk score, so the PRS score. So in people who had higher PRS scores and they took hormone replacement therapy, their risk of developing breast cancer was higher. And what we really need to do, and there are things that we do with this, is factor in other things like family history and prior biopsies and all of the other clinical factors that would normally go into assessing risk. But combining that with the PRS score can actually give us a better sense of risk. So I wouldn't say everyone should go out and do this, but I think that if you have a family history or another risk factor, or you've had multiple biopsies, and you are worried about hormone replacement therapy, but you want to take it, this is something to consider and to consider talking about. Most people will say it's too early, and I agree, but I think it's a tool that could be used. And we currently, at Vanderbilt, where I work, we actually have a large study of over 10,000 women. It's called the Emerge study, and I believe it just completed enrollment, but we can check. Just anybody can come and enroll, and you get the PRS score, and they're actually looking at 10 different diseases, including the risk of developing atrial fibrillation, asthma, colorectal cancer, breast cancer. I think those are the only two cancers, but a bunch of different diseases. And then they're following these people. And you go on, live your life. If you get hormone replacement therapy, you report that, you report everything to follow prospectively what happens with a different one PRS score and an intervention. So, I think that's pretty fascinating. I think that's the right way to do it. But if the study's closed, and you do have risk factors, and I think it's worth talking about getting this test done, just as you would talk about getting the BRCA test done if you have a strong family history.
So let's talk about that. So I am in a more high risk category. So I'm already doing that track of trying to figure. I'm not at the place yet to make the decision for HRT yet, but when I do come to that place, I am going to have to negotiate with the risk. I'm curious though, for the average person out there, what is the due diligence that we need to do for the risk factors before we say yes to HRT? So who do we need to talk to? What scans do we need to do? Is it just a mammogram and we should feel comfortable? Is it just talking about what our family history is? And what is the family history that should elevate the risk? Is it a great aunt that we should consider, or is it just my mother, my grandmother on the maternal side? If I don't have anybody there, then I should feel like I'm pretty good for HRT.
Yeah. So having a primary relative with breast cancer, meaning parent, child, sibling, doubles your risk of developing breast cancer. That sounds huge, but again, the lifetime risk for someone, average it out depending on the study, is about 10%. So that's the lifetime risk. At any given year, it's a lot lower than that. So, the doubling sounds huge, but it is big, but it's not as big as it sounds. 2 primary relatives could quadruple your risk. Then you go on to second degree relatives, as in an aunt, an uncle, or a grandparent, or grandchild even. And there's an increased risk, especially if the person was diagnosed at an earlier age, or and if they have a genetic mutation, you should probably be checked as well. Once you get past that, like a cousin, a third degree relative, that would be really younger and multiple. So diagnosed at below the age of 40 and multiple. And then also ovarian cancer. Ovarian cancer is in its own special category. So if there's a person diagnosed with ovarian cancer, they should be tested immediately for any genetic markers, and younger prostate cancer.
Okay, so where do we go to get genetically tested? And who would say that, yes, we can do that? Like,
the first place to start would be your primary care doctor.
Okay.
There are high-risk clinics, but that would need a referral. And that would be if you really do have, for whatever reason, some family history, multiple biopsies on your own, even if they were not cancer, but atypical cells, or not even atypical cells, but you've had 5 biopsies for things that have popped up on mammograms. That can increase your risk. And there's certain models that people can model out. Like there's a model called the Gale risk model. That's one of them. So you can actually go online and put in all your information and get a risk assessment yourself, but really best done by your primary care
doctor. Okay, and then because I've just been in this terrain with you, so I'm just going to ask this question for everyone else out there. So due diligence is that we get a mammogram every year, right? But now I guess they are saying that maybe we should be getting an MRI scan too, and maybe that's actually better for catching things? Or do you only get that because something showed up on the mammogram?
So currently it is just a mammogram.
Okay.
There are categories of people who would get MRIs, like somebody who has a BRCA mutation, possibly somebody with extremely dense breasts. That could be somebody who might need an MRI. There are different categories, but for the most part, it's really people who, it's really just mammograms yearly.
And we can feel good about that.
We can feel good about that.
I'm just so for people that are trying to navigate the risk, if they don't have a family history and they're getting regular mammograms that haven't shown in everybody, they've got the green light.
Yes. And, at this point, most places are offering 3D mammograms or the tomosynthesis mammograms, and that's really great. I would recommend doing that.
And is the reason that you and the other doctor and your nurse practitioner said we're not taking hormone replacement therapy, is it because you see such grim things coming across your desk and it's just scared you to say, I'm going to try to go au naturel, or is there another?
Yeah. So yes, we do. We see the actual cancer. So that is what we see. So there's definitely that bias. But I would say that depending on the symptoms, I would. I really would. And I also want to say that, I would look into, potentially looking into the PRS score, but there's also another drug called Duovy, and you've, I think, prescribed it, Duovy, which is estrogen with it's not with progesterone. It's actually, if any of you have heard of tamoxifen, you've had friends who've had a history of breast cancer who've been on it, or you are on it. It's similar to tamoxifen. It's a selective estrogen receptor modulator. And it is now it's FDA approved for postmenopausal women for help with osteoporosis and hot flashes and other symptoms. And what we've found is that it actually decreases breast density, so maybe helpful there, and potentially decreases the risk of breast cancer. So there is a clinical trial going on right now looking at perimenopausal women with Duovy, so they get all the benefits, and seeing if this particular clinical trial is looking at seeing whether people with atypical cells or precancer can prevent that from becoming cancer by just taking Duovy rather than going through a lumpectomy. So if it works there, I will say moving earlier to just hormone replacement, absolutely.
Wait, say that. So we can take the Duovy instead of HRT?
I'm gonna talk.
Yeah?
Yes, defer to you because you actually do this. So, but I think that it's an interesting drug because it's even being studied to prevent breast cancer, and yet it has the estrogen in it, and it helps with those symptoms.
But it doesn't have the progesterone. So
it does not.
Would we supplement with the progesterone?
Katie.
So Duovy, the progesterone part is the selective estrogen receptor, so that acts as the protecting feature for the uterus. And so Duovy is awesome. And that is one of the things.
This is new. I haven't heard of this.
I think that really the selective estrogens will become the standard treatments, and each selective estrogen has different benefits in different tissues, and so they work differently in the vagina. There's Ospina, I don't know if you prescribe that much, but so there are some that work differently in the vagina, some that work differently in the uterus, some that work differently in the breast tissue, like tamoxifen. So they'll each have their own prevention and treatment. But Duovy is great in a niche category. It's great to try, firstly. So if you just want to dip your toe in and you're really worried about breast cancer, it's a great one because breast density is reduced, and that's an independent risk
I think we
factor
just
for
found
breast
our
cancer.
third thing,
But
and we've not heard of it.
I will say
Duovy.
that it has a lesser ability to control severe symptoms, especially in the younger women. So it wouldn't be very good for perimenopause or really early menopause, but as you get further into menopause and don't need quite as much progesterone support or estrogen support, it's awesome. And we'll oftentimes try to transition people from estrogen and progesterone to Duovy as they're getting closer to age 60. Duovy still carries the same risk for strokes and blood clots, but it's awesome.
I think
I'm
we just
excited
had a
for that study.
revelation.
You have to
we
email
not?
me when that study comes out.
Yes,
I don't
will.
know.
Yeah.
Have we just had a revelation? Because it seems to me like we said 15 minutes ago that we're going to stay on HRT for 10 years to 12 years, and then we actually have something else that we can go on, which is Duovy.
I think by the time
Right?
all these women in this room turn 60, we're going to have a SERM that will really be amazingly helpful and safe.
Right. And this Duovy, the SERM part that I was mentioning, like the tamoxifen part of it, it has anti-estrogen effects in the breast and in the uterus. So
I mean, I feel like I should go on that tomorrow. Should I not?
it's
Should
one
we
of those.
talk tomorrow?
It's one of those things where if you ask what would I do with that fear in my mind, I think it's something that I would consider. And there are all these things, but again, I have to caution. We don't have the data fully. I mean, you're using Duovy, and I think it's FDA approved only for postmenopausal women, actually in menopause, but it's being studied in perimenopause. So, it's out there.
Okay, I feel like that was a revelation, right? Like I'm making a phone call tomorrow, maybe? I don't know. Okay, so I want us to give, I want to give time for people to ask questions, and so I'm just going to go quickly through this last thing. Creatine. Should we all be getting on creatine? Because Mary Claire Haver's on it, and she says we should be.
I think it's a little bit of a data-free zone.
Nobody knows anything?
I'm not sure that the benefits are what they tout, but
Okay, should we be, well, go ahead, I'm sorry, I don't want to cut you off, because I think some of us probably want to be on it, so
okay, right.
should we or should we not?
I think it's probably safe. I think it's one of our better studied supplements, but I'm going to make this point that if we look at supplements, they are really not a shortcut to better health or prevention of disease. They just really aren't. I think you'd be better off eating an apple a day or focusing on getting better sleep or trying to take a walk after a meal, because those things are so proven to benefit you in reducing risk for dementia and heart disease and bone loss and all of the things, much more than creatine. So I think the data for a lot of supplements is just not robust. And I think that everything you put in your mouth has to be processed by your liver and your kidneys or both. And so you put stress on them in doing that work. And so you just have to be super thoughtful about the hype and cut through that hype with stick to some science, I think.
So we've got a question mark on creatine. We might have to come back to that. I have put on here supplements and other natural aids, and I have put decreased alcohol, because unfortunately, for many people, alcohol no longer is your friend.
Can I make a comment on that?
Yeah.
We talk about the Women's Health Initiative and the study and the increased risk of breast cancer. It's really the same risk that you'd have by having 2 drinks a night. So.
Oh, so if you're having 2 drinks a night, you're having the same
as
risk
being on
of
hormone
getting,
of the synthetic
of me
hormones,
taking the patch or the cream.
Of the synthetic hormones, the riskier ones.
So alcohol is no longer friendly or fun.
Well, it's still a small risk, but they all add up. So I guess I'm trying to say, if you're, one versus the other, or think about it as it's a holistic, all the different habits. So.
Okay, so I had a very humbling experience in Katie's office, because we were going through the things that she thought I could do naturally, and she told me that I should start taking Centrum Silver, which honestly, I got in my car and I thought, I don't know if I like her. I'm so sorry. As I'm having a hot flash right now. Centrum Silver, that was very humiliating. But you seem to like Centrum Silver, recommended. So that's why I put it back on the list, because maybe there's a benefit and we could take the ribbon around off the jar and keep it in our cabinets.
Okay, so especially since I'm on film and all that, the data, there's a study that's awesome. I think it's called the Cosmos study. 200,000 women over, I can't remember, 15 years that took a multivitamin every day, and it decreased morbidity and mortality. And so I think a multivitamin is pretty reasonable, and it kind of fills in the gaps where maybe we're not eating perfectly. And the vitamin they used in that study was
Centrum Silver. So we don't have to go get fancy. We can just go to Walgreens and buy Centrum Silver without anyone seeing us.
Money for something more fun.
Okay.
I think there's some data for vitamin D, and maybe you can speak to that. I think that vitamin D for women is probably pretty reasonable if you want a second supplement to add to a multivitamin.
I mean, vitamin D, like every study I've read for autoimmune, every disease that you can get, depression, all their levels were low on vitamin D. Like, I do not take vitamin D. I'm taking it every day.
Absolutely. And
right?
I think, and a 2,000 international units per day type thing.
2,000.
Don't do those 50,000 unless, even if your levels are really low, then go up to 5,000 a day. I don't know about you. I don't believe in that 50,000. The bone, there have been studies that have shown that it's not necessarily the best thing to do the 50,000.
2 quick questions, because we could talk so much, and I have so many more questions, but I'm going to do 2 more. Hair loss. Will it ever come back? I know every celebrity's taken Nutrafol, but I'm not sure that it actually works. Is there anything that you can actually do that will increase your hair?
I would say number 1, see a dermatologist just to make sure you don't have any other scalp problems. Minoxidil. Rogaine. It's extremely effective. So if you have no other scalp issues going on, you can use topical or
You
oral.
put it on your head?
So I think that is data proven and safe.
Where do you
and
get
effective.
that? Just at the drugstore, or you have to get a
Walgreens.
prescription?
No, it's at Walgreens. The oral, you have to have a prescription, but I would definitely say a dermatology visit is pretty reasonable for hair loss.
Okay. And, okay, so hair loss, I said that one. You know, not to quote Mary Claire Hafer again, but she said we all should be eating lean protein like it's our job, and we also should be wearing weighted vests around our houses and everywhere else in God's creation. So I'm just wondering, is this protein thing a thing? And then also, should we all be wearing weighted vests everywhere we go?
This is just as a general, I mean, because I treat breast cancer, so it's, but you know, people have loss of muscle. So I think protein is very, very important. I do think people go over and beyond. If you're taking a protein shake, please drink lots of water so you don't end up with kidney issues. That's a huge one. Protein is really, really important, but so are carbohydrates and fat. So you need to be balanced about that. And one thing I always tell my patient population is really the diabetic diet should not be called a diabetic diet, it should be called the normal person's diet. And really a big part of that diabetic diet is when you have a carbohydrate, you have to have a protein to slow the absorption. So I've worn one of those glucometers just to test it out and see what happens, the continuous glucose, fascinating. A brownie, my blood sugar shoots right up. A brownie sandwiched between cheese, so the French know what they're doing, blood sugar's much more stable. So make sure that when you are doing these things, you're taking the protein in to slow down absorption, have some fat as well. But protein is very important. It's just, I think, going crazy with it is not a good thing.
Okay, so I am going to step down and see if there are any questions. So maybe I'll take your mic and let's hope I don't buzz coming down. Does anyone have any questions? Shirley, did we answer all of them? Okay, good.
So when you were talking about estrogen, I get migraines, and it's always been hormone, because of hormones. And I have an IUD, which I thought I was going to get the estrogen part for the hot flashes. And they said, nope, you can't do that because I get the migraines so bad. So is there something that you would suggest that could work for someone with migraines?
Okay.
Use Vandana's mic.
Tell me if you can hear me. Migraines, people with migraines, we believe, have a lower threshold or a higher propensity for stroke. And so migraines and estrogens don't always go together very well and can be an absolute contraindication for using birth control pills over age 35. And really, you want to be thoughtful about using hormone replacement that contains estrogen as well. So,
Because it'll increase your chance of getting more migraines?
Migraines and strokes. So I think that typically people who need estrogen but can't use it for whatever reason, breast cancer or whatever their reason, they're really great candidates for some of the newer medicines like Veoza, which is in a class of its own, which we have, I think, 3 more in that class coming within the next year. So there's still other things that you could do. And I would probably say you're a great candidate to look outside of estrogen therapy.
As someone who's had a partial hysterectomy, I don't have the cycle, knowledge of how long it's been. And I have the patch and all the things. How will I know when I'm finished with the craziness of all the symptoms and?
Okay, that's a great question. So if you have an IUD and it stops periods, or if you had a hysterectomy and it stopped your periods, but you still have your ovaries and they're still doing their thing, really the only way you can tell if you've gone through menopause is to check blood levels. And so blood work can help you.
Yeah, I've had that, and I am in the middle of all the things. I just didn't know.
Yeah, and so the other thing that is probably the most important is, like, if you're still having symptoms and you haven't used hormones for more than 5 to 10 years, or you're not over age 60, then you treat the symptoms. And it doesn't really matter when you're officially defined as menopausal. Is it 51 or 52? It doesn't matter, because we're still following the guidelines for hormone use.
Is there an age you'd recommend somebody getting a DEXA scan?
I think the official guidelines would say 65, but Medicare doesn't cover a screening bone density very favorably. And so the other risk factors, I'm generally thinking about one in their mid-50s for women. If you're on thyroid replacement, if you've broken a bone for no reason or had a stress fracture just out of the blue, if you're really small stature or small framed, if you've used medicine for reflux, if you have a family member with osteoporosis, those are all reasons to get one at an earlier age. And so I think it's pretty reasonable to get one in your mid-50s. If you have risk factors, you probably want to get it a little earlier.
So much cooler down here, y'all, just so you know.
Thanks for being here tonight. It's been really helpful. My question is about supplements that are like food-based that say that they're connected to estrogen or progesterone. So, for example, like the rhubarb supplements where it's like, eating 4,000 stalks of rhubarb or take this small pill. And or soy or any of things like that.
Sweet potato,
Yeah, sweet potato or the black cohosh or anything like that. Is that all black cohosh hogwash or is it like a real thing?
Okay, I really think there's very little data for those things, but I want to ask you too what you think about soy, sweet potato, yams, and their estrogen content, and what you think about that with breast cancer.
So we generally say, black cohosh, probably not a great idea if you've had a history of breast cancer. It does have estrogenic effects in it, so we generally don't want you to do that. The issue with a lot of the supplements is that when they're not regulated and when they're actually tested, what we find in them is not what is on the label often, especially with certain ones. So really, really be careful. And I think when people say that they started taking a supplement and their hot flashes went away, my first thought is there's estrogen in that supplement.
So it really would be it would be similar to taking actually studied, measured hormones with your doctor, but you're just playing a little bit of a wild card, and it's in a cuter bottle.
Yes, exactly. Exactly.
Thank you.
I mean, this is your moment. This is your moment. Ask away.
So my question is, what have you noticed with different types of, sterilization procedures, like what that's looked like? I'm on the front end of, I don't have any symptoms, but I got something called Assure, and I don't know anyone else who's had this, and so I really don't know what this is going to look like for me. I'm coming up on 55, but so no symptoms. I'm all good to go. But so what have you kind of noticed if you see people use different procedures, how that plays out?
Yeah, great question. So generally, things like tying your tubes or the Assure coils are pretty neutral when it comes to menopause. And I think if you're 55 and you haven't had a period in a few years, you are probably one of the lucky ones that. Oh, sorry, I didn't hear you correctly, but. Okay, yeah, I think Assure is completely safe. There was a window of time where it was used quite a bit. I think it's no longer being produced for a lot of different reasons, not because someone like you would have safety issues, but it should be neutral as far as how you progress through menopause, what kind of hormones you decide to use. It really shouldn't affect that. Same with having your tubes tied. It really doesn't change. If your ovaries are removed, obviously that's a different story because that puts you into menopause immediately. But with the Assure coils, you probably will be fine. And you can't tell your friends that you don't have any symptoms because they'll be upset with you.
The vaginal or just HRT? The HRT cream. I think, can you put HRT cream anywhere? Or are you supposed to put it on your arm? Or inside your thigh?
Okay, great question. Really, you shouldn't put it anywhere near your breast tissue, is what I always advise. Most people put it on their forearm or their inner thigh. Testosterone can make hair grow wherever you put it. And so that's something to think about. And I generally don't recommend putting hormones on the vulva or the breast.
Where does the patch go then?
The patch is usually kind of on your flank, and are on your lower abdomen or your back. And again, not near your breast tissue.
So my children sometimes call me a hippie and in jest, but I sometimes like to think outside the box a little bit. So I had hot flashes come into my life overnight, and it was like 15 a day and really overwhelming. And I went to a Chinese acupuncturist, and they vanished. So that's my first one. And then my second question, I know enough about Casey Means to be dangerous, but I listened to one podcast about food. To your point, whoever, I can't remember which one said about eating an apple a day, walking after dinner, having proactive ways to curate health and wellness. So I know it's a little bit off the grid as far as what we're talking about, but I'm just curious about how that plays into perimenopause and menopause.
Okay, I love that question.
I'm
and
channeling you.
I don't want to
Feel
hog
the
the
same.
mic, but I think that this is a moment in time where it's super. I love it when women come in and say, "What else can I do besides hormones?" Because there is so much we can do at this moment to reset and to propel us into the next few decades to be healthier. And honestly, we split hairs over hormone therapy and which one to use and whether to give it topically or orally or how much and how long. But what is much more profoundly impactful for our lives and our health long term is not our hormone replacement and not our supplements. It's how we take care of ourselves. And a high fiber diet, plant forward diet, Mediterranean diet, getting good sleep is imperative, and it's really hard at this phase of life. And keeping social interactions robust, fostering friendships, exercising, just moving. Those things have so much more data and proof to support benefits for health than any of this other stuff we're talking about tonight. So I love that question. I mean, I think I was kind of thinking about that in case someone asked tonight, like if I had one hack, what I might say. And I really love, women are always like, I kind of know what to do, but I just can't make it happen. I think if you think of something really small and take one thing and try to just do it every day. And my thing, I think right now, this week, would be eating a lot of fiber and eating it in your food. And fiber comes from plants. And so, I don't know, one guy says, like, if you can eat 30 different species of plants in a week, then that's awesome. Or getting 30 grams of fiber a day. And it's really hard to do. Actually, that was kind of my thing for Lent, as I tried to do 30 grams of fiber a day. And I was like, oh my gosh, there were not that many days that I actually made it. But it's something super small, but it's super relevant and super beneficial for you, just to increase your fiber intake. But y'all can talk about lifestyle too, if you want.
Anybody else? You got one? Great. Good.
Okay, so for a menopausal woman, is there a world in which you would be doing a vaginal estrogen as well as an oral? If the vaginal treats certain symptoms but not necessarily others, how does that work? Just curious.
I think Sarah would tell us all yes.
Yes, I think yes.
I agree. And I think the data would show us about 30% of women don't get enough vaginal support from systemic estrogen that they might need a vaginal estrogen. So the answer is yes. And it's safe, compatible.
Yeah, you're not going to overdo it because the systemic absorption vaginally is basically zero. So you're getting symptom relief from that. We're not overlapping with the HRT.
Anybody else? No? Okay, so to conclude our evening, I would love to go through our panel and each one of you give us some word of hope for this transition in our lives. It could be as simple as uptake of fiber or I don't know, go get the genetic testing, or go get your vaginal estrogen tomorrow. But something that you feel like will actually make a difference and can improve our lives. You got one.
Okay. I think my big takeaway is get advice and talk about it, because we don't have to be afraid. We don't have to go crazy with it. There are so many things that can help women. And I talk to people about this every day. The symptoms are super real and they really can be difficult. And there is help. There are lots of different ways to help with the symptoms in really safe ways. So I love that we're talking about it tonight.
Could you offer one thing? Let's say if I threw out sleep and we're not ready for progesterone or HRT, is there something else we could do that would help our sleep naturally?
Okay, sleep. We didn't really talk about that, but
No.
I think that cognitive behavioral therapy is proven to improve sleep. That's one. I do think magnesium can help women sleep. There's not a lot of data about what kind, how long to take it, but I think in general it can help with sleep. And I think really healthy sleep habits, sometimes we miss those. Don't use your screen before you go to bed. Try to keep your sleep in the same intervals, like try to go to bed at 10 p.m. every night instead of 9 one night and 12 the next. Take the TV out of your bedroom. Only use your bed, for sleeping, not for playing a game or watching movies. So there's lots that we can do to promote sleep. Hormone therapy, I will say, is extremely helpful with sleep most of the time. And honestly, if someone comes to me and it says they're having trouble with sleep, I would say that is reason enough to use hormones, because sleep is so important, and that's when our bodies rejuvenate and heal.
So, from a breast cancer perspective, I'm going to say two things. The first is, there's that scare part of it, and I hope I did talk a little bit about just assessing your risk, but also just sort of thinking about there are, beyond these benefits, you have to look at yourself. For colorectal cancer, hormone replacement therapy can actually decrease the risk of colorectal cancer. So if that's what your family history is, maybe it would actually benefit you more than increase your risk for any cancer. So remember that it is a personal risk assessment. But the other thing I'd say, just in general to do, is the importance of exercise, especially walking briskly or some other exercise for an hour a day. It's one of the few things that has actually shown to decrease the risk of recurrence of breast cancer beyond just chemotherapy and the hormone blockers. It's studied pretty extensively, that and low alcohol intake. And we know it helps with your heart and and the mind. So that would be my takeaway, is to make time to do that.
I think one thing I love to tell my patients is be your own best advocate. And I think coming here tonight and going out and trying to educate yourself is a great first step. But don't be afraid to have conversations with your doctors or your peers and talk about difficult topics, right? I think I'm in urology. I'm talking about difficult topics all the time, and waiting 3 years. I've never heard that statistic, but that's ridiculous. So, if you have some symptoms, get yourself out there and educate yourself and make good decisions about health, because you're the number one.
Well, thank you, all three of you, so much. I hope this was helpful. And I'm going to put this up on my website. And then I'll also give you links to where you can contact them if you want to ask any more questions. Or you can go through me, and then I can field the questions through you, whichever way. But thank y'all so much for coming, and I hope it was helpful. And I hope you do feel a little bit of hope, or at least more hope than you did when you came in tonight. Thanks for coming. Thank y'all.